So Debu brought up Monarch 2, okay, which is being presented at this year's ASCO. Carlos, are you familiar with the Monarch 2 design?
I am. Monarch 2 is a study that uses abemaciclib, the third CDK4 inhibitor, that may have subtle differences that may or may not matter clinically in that it has a better inhibition of CDK4 over CDK6 compared to ribociclib and palbociclib. It's also the one that has shown single-agent activity in Monarch 1 trial. So these are subtleties that, again, anticipated this would be a pretty good CDK4 inhibitor. Monarch 2 is a large randomized study in second line. The randomization was between fulvestrant and abemaciclib versus fulvestrant alone, and placebo, I'm sorry. The other difference with this trial is that the CDK4 inhibitor was given continuously. The toxicity profile was a little different. Less myelosuppression, more diarrhea. Probably consistent with the fact that CDK6 is inhibiting less and CDK4 is inhibited better. We will learn more about the tolerability and management of this diarrhea, but it can be a bit of an issue, I think, as of now. So the hazard ratio in the study was way in favor of the combination, 0.55, with a difference in progression-free survival of 9 months versus 16 months. So that is remarkable. The other thing worth pointing out about this study is that these were patients that were totally chemotherapy naive in the metastatic setting.
I was going to ask you that.
And this suggests that maybe fortuitously or intentionally, this study identified a truly ER-dependent population, in that at any point before the trial enrollment, no clinician had an inkling of giving the patient chemotherapy, which, sometimes is driven by a perception that maybe this tumor is not that hormone dependent. So that is different about this trial and may explain the quite the impressive progression-free survival in the control arm in second line.
Right. No, it is. I mean, it's really, you think it was 4, it's usually 4, and 4 for fulvestrant alone.
Yeah.
And from effect, and then from the Palbo trial at least, it was about 10 or 12. And now you have 6.7 and I think, or 9.7 and 16.
Correct.
That's kind of, and I'm struggling trying to understand that difference. And it could be that the fact they didn't get chemotherapy. Mm-hmm. They were truly
could be that.
Population.
Could also be that there's some that abema may be a little better. I don't know. We will find out.
Right.
Okay.
It's a great question. Has anybody had personal experience with abemaciclib?
Yeah, I am the principal investigator of the Monarch 1 study that we just published last week.
Right.
It's a different drug. I think it's a different drug. I think Carlos is right on. It probably hits CDK4 more. We don't know how this will play out. It has activity as a single agent, but it also has diarrhea. Now, diarrhea could be something of concern when you are talking to combine this with fulvestrant and other AIs. So at the end of the day, I think that Kim was making the point, we need to get data on all these scenarios, and we will decide based on the data that we'll gather.
Right.
And it's going to be impossible, but I would agree that this is of the 3, this is the one that is more different of the
It is. It's much more potent. The IC50 is a lot lower, isn't it, than the other drugs and things like that. And it's going to be very interesting to see what happens, I think, with this drug, especially for Monarch 1. I mean, would people, God forbid, this is not FDA approved, would they, if it gets approved, would people use it in that setting based on Monarch 1? Monarch 1 it was heavily pretreated patients, right, getting a single agent.
And we had a very interesting activity, and we're talking about partial responses in patients with positive disease, and they were not small. But I do think that these agents will need to be given in combination with chemotherapy, with hormone therapy. I don't see.
As a single agent.
Okay.
I think the other interesting thing too is the trials that are ongoing in patients with CNS activity, because it has penetration into there, so it'll be interesting to see.
Do you think it's going to be a class effect, though? You think it'll be the class effect on everybody? I mean, you had a great paper, by the way. You were part of a great paper in Science Translational Medicine I just saw. With her, that's a whole different story about HER3 and phenotype switching. But do you think this is going to be a class effect on all brain mets, guys, or not? So in other words, will the CDK4, it won't matter what CDK4 you give, it'll get CNS penetration? Or will it be specific to a drug?
I think some of the preclinical models suggest that there is actually better CNS penetration with abemaciclib, that it is an agent specific.
Really, seriously, it's going to be agent specific?
Well, the human studies haven't been done, but this is from preclinical models. It does have
really?
better CNS penetration.
And there are a number of studies now that are using abema, that will be using abema post-progression on palbo or ribo.
Right. Right.
And,
So
and
those
there's
will tell us whether
What's going
there may
on.
be some not complete cross-reactivity.
Right.
and there's an ongoing study specifically for CNS metastasis with abemaciclib ongoing.
Okay.